My name is Dr. Christopher Kerr. I'm coming from Buffalo Hospice and Palliative Care, and I'm a guest of Crossroads here in Batavia, and I'll be speaking on the 22nd about the topic of our research in this book. You can learn more by looking at my website, which is drchristopherkerr.com. I'm coming here to speak to really cover the work of our research that's been going on for many years. It's also been featured in a Netflix special and a PBS documentary. And what it really focuses on is the patient's experiences at end of life. So rather than necessarily a medical view, it's really the view from the bed. And the talk will feature a lot of videos of patients and their families. There's the dying process we see, which is objective or physical, which is generally decline, and sometimes there's suffering, but there's a lessening. But then there's also the experiential side. So what's the patient actually experiencing? And dying is an interesting vantage point. You know, forces you to reflect on your life, to perhaps reassess and remember and recall. And it's hard. It's an experience that's hard to imagine, and so when people are in it, it's very unique. And what comes from them is that they often recall and remember the best parts of having lived. Um, this recollection often comes in the form of dreams, and they tend to be very comforting and therapeutic. And in the end, I think what they do is they affirm the life led. They don't deny death, but it's a much more positive and comforting and meaningful story than what we would anticipate from a position of health. I was more forced to see this other side of it from my colleagues in nursing and pastoral care. That, dying is more than organ failure. It's the ending of a life, and that we are more than failing parts. And when you look at it from that perspective, the patients, it turns out, have a lot to say about it. And that's where it started.
How did your perspective change?
A lot. I certainly started off cynical, and actually more discomforted by it. It's easier to play the doctor role in some senses. There's algorithms to it and things that you do, and it's very hard to stop and instead of doing something, just be present. Present in a way that allows you to know the patient as a person, to hear their hopes, their fears, um, as well as what they're experiencing. That's a different role. I trained as an internist, and I moved to Buffalo to pursue cardiology. And oddly enough, I was just looking for a moonlighting job to support my family and saw an ad for hospice doctors on the weekend. And I started doing that, and I wasn't doing it very long, and I realized this was the most rewarding, meaningful work I had done as a physician, and that was in 1999, and I really never looked back. The sacrifices of medicine are, are made harder when it's not rewarding, when you can't spend time to be the type of doctor you wanted to be. And when I got to hospice and realized, wow, I could take a breath, pause, sit at the bedside, really communicate meaningfully to the patient, know them, know their family, um, then it became what it was supposed to be, which was a privilege. And that sort of uh, work became more meaningful. I had a gentleman who was dying of complications at that time of HIV, and he was very alone, and he was in his 40s. And I thought that we could have more time if we treated him for infection and hydrated him and whatnot. And I walked into the nurse's station and said, let's order this, this, and this. And there was a senior nurse who didn't so much as look up and said, oh no, he's dying. And I said, well, how do you know that? And she said, well, he's seen his deceased mother. And I had never heard anything like that in my life. And of course, she turned out to be right. And then what really struck me in talking to him was how real that experience was for him, and how comforted he was by it. So then what happened, I guess, is that it didn't matter. The issue wasn't what I believed, the issue was what he was experiencing. And in that way, it was so clearly therapeutic for him. And that's really our obligation, is to comfort. And if that was comforting and it was real, then it was valid for him. And I didn't have to understand it. I don't have to know its source. I don't have to disprove it. I just think you learn to have reverence for what they're experiencing at the end of life, and just to be respectful and to honor it. What led me into research was enormous frustration. I was trying to teach the importance of the patient experience at life's end to students and residents, and the response I normally got was, well, there's no evidence for that. You know, we live in this evidence-based time. Because this isn't something you can image, take a picture of, do a blood test for. Um, and so they were right. There wasn't a lot in the medical literature. So that led to the studies. And what happened beyond that is really a story unto itself. We published our work. We probably published 7, 8 manuscripts in medical journals and got very little response. But then what happened is it seeped out to the non-medical community, and it ended up in the New York Times, Washington Post, the Huffington Post, and it just continues to go around the world to this day, which is really interesting because there's a disconnect then between what the clinical world think has value and what the people who are receiving our care thinks has value. I think there was a horrible fear that loved ones were dying without us, that they were alone and that they were isolated. And that led to this horrible feeling of helplessness and of being disconnected. And I think that the more discussion there was, that, you know, people may be alone physically, but they're not dying alone um, existentially or psychologically or spiritually, that they tend to be recalling the people that they loved and that they lost. And that those experiences in our studies feel near virtual for them. So again, it doesn't seem to be dependent on a physical presence, but on drawing from the memories of having lived, so that it's. I think there's comfort. There's a comforting story or message in that. So in our studies, these are university-approved studies. We're not talking about the minutes or hours before death, right? We're talking about the days, weeks, and sometimes months before death. And when we follow these people every day, and they're all screened for confusion, and that's what's so important in what we did, is we filmed people. So seeing is believing truthfully, and I can't do them justice. So when you look at these videos, you'll see that they look and sound like you and I, so they're not confused. When we did that, nearly 90% of people were able to report at least one experience. And nearly 90% of them were comforting. And what happens is people get closer to death, the more these events become more frequent. But what's interesting is that's when they start to see people who they've loved and lost. And there's this editing process, so they tend to not see people who conditioned or withheld or hurt them, but they do remember people who secured and loved them well. And when we looked at comfort on theme, those were the most comforting themes. So there's this built-in mechanism: as you're getting closer to death, the more likely you are to increasingly experience the presence or the familiarity of people who you've loved and you've lost. It's funny. I have a PhD in neurobiology, so I'm not unaware of brain function, but I can no sooner point to the origin of this than I can the origin of love. To me, these are abstractions. I'm not sure that understanding the mechanism is really the point. I think that's actually one of the problems we're in medicine, is that it has to be there has to be an organic basis for everything, and that's really not reflective of the human experience. There's lots of occurrences and experiences that aren't definable. That doesn't make them less true. I just think that's something that unfolds when it should. nature, God, whatever. There's another version that we can't anticipate. And these, I should tell you, are very different than near-death experiences, which are, people come out changed from and need to share. That's not what these are. Going into the light, that's not that. It's really recalling people. It's about relationships. It's mostly about love. Um, and time and distance don't seem to matter, so you can be very, very old and you might have lost a parent when you were young, and it's their presence you're experiencing, it's their voice you're hearing. It's that reassurance that you're not alone that really comes out. So we've done a number of things. I mean, we've published results of children at the end of life. We've looked at the effect of this on families and grief. We're actually doing studies now that are looking how these experiences change the person's view of their life and their belief systems, for example. I think asking those good next questions, the deeper we get into it, so that you start off saying, "Does this occur? How often does it occur?" Almost demographic type things, to richer discussions of what does it mean? What are we supposed to, what does the patient take away from this? What can they tell us and share? And it's really interesting. They may be dying, but their words seem to matter. They all want to participate and tell their stories, the real stuff, the hard stuff. I think that there's a perspective that we need to consider, which is that of the patient, and that I think that there's a better story, that I think that death for most of us is a fear that with lots of unknowns, and it's a void. And I think hearing from people who are actually doing it, I think that I hope that is both comforting and meaningful, because it's less fear and anxiety and pain filled than we imagine. I think we naturally imagine the worst. It's just a perspective we don't have. People, we live to fight against dying, but people who are actively dying reach a point of acceptance, and again, their perspective and their perceptions change, and I think there's something to be learned from them.